you can see the pelvic floor. This netting of muscle is the pelvic floor. And it sits there, again, it can absorb forces from above, but there are small nerve twigs that are innervating that pelvic floor, and they're coming from the spine. And they come out in nerve roots, they break up into plexuses, and then they go to that pelvic floor. From there, they're affecting bladder function, bowel function, sexual function, so they're in play. So and in this model, you can see the uterus and the bladder, they're removable. So if I take them out, you can see the pelvic floor. What's hard to show are those nerve twigs. But those nerve twigs are going to these muscles, and if we're going to re-recruit that pelvic floor, I think at some level you have to address any loss of nerve function that's occurred because of childbearing, because of time, because of other insults that have occurred over the course of a lifetime. But when I take these organs out, you can see the bladder is sitting right on top of that pelvic floor. And the uterus, the cervix, they're right at the top of the vagina. So all these organs are intimately connected. We tend to separate them. When we study them in medical school, we break them down into these categories. But the truth is, within our bodies, it's all one unit. So it's like a balloon. If one thing is affected, it's going to affect the other areas that are close. There is some nerve damage with childbearing. That can cause some sense of urgency for some women after they deliver. And then that's exacerbated by their life. They are in the grocery store and they feel the need to go to the bathroom, and their brain says, not now. I'm too busy. I got to get the groceries. I got to get home to put dinner on the table. The restroom's on the other side of the grocery store. I'm not going right now. And over time, the bladder just begins to ignore the brain. The bladder says, look, the brain doesn't care what's going on to me, and I'm hurting here. I got to go. So the bladder just contracts and overrides those signals that we learn when we're young that our brain is sending to us. And as that occurs, again, a patient can try to compensate for that, but ultimately the bladder wins. And those nerve pathways get fired so many times that the brain just has more and more difficulty controlling the bladder. And this is important to me, is this concept of nerve-sparing surgery, that when we take patients to the operating room, we have a plan and we know the anatomy well enough to either avoid those nerve plexuses that are in play or dissect them away so they're not injured or damaged during our surgery. And that really helps create functionality afterwards. So these patients not only have their prolapse fixed, for example, but bladder bowel function is intact or improved from what it was preoperatively. And I think that's an underappreciated thing. I think in the years to come, you'll see more and more emphasis on that. And it's something we're already doing, but I think it's a very, very important thing.